joining us today. And she is going to help me with the developmental part of this. I'll do the genetics part, and then she's going to come in and hold on here. There's something. 1 minute. Let me look at it. I've got something coming up here. Doesn't matter. Anyhow.
Just click got it and I'll go in.
Okay. Where's my mouse? Where do I?
It's on the other screen. Drag it over.
Drive. Oh, come over here. What do you mean drive over? Oh, here we are. Okay. Here, I got it. Yeah, got it. Thank you. All right. Okay. So now when you look at this, going into the board review, what I asked Dr. Cobb to do, and she so graciously did, and she'll send you, is kind of a cheat sheet on developmental. And again, maybe this is my own lack of, but you know, sometimes those things get very confusing to me. And it's the kind of thing that before you walk into the test, quickly review. So she's put a sheet together for you on developmental, and it may help you right before you walk into the board test. Just look at that and get a couple of those 3 things in your mind. Development is a big part of the board review. Remember, this is your pediatric board is a general peds board. And sometimes I can get in the weeds, you know, with the unusual cases, and they probably won't bear any fruit for you on the board test. Whereas developmental, very much a big ticket item. So you really need to concentrate on that, just like infectious disease. If you look at genetics is only probably about 2%. So it doesn't bear as much fruit as development, infectious disease, et cetera. So Dr. Cobb put this together. She'll share it with you. And it's just one of those things that, like, I used to just kind of look at a couple of things before I would go in, because I would get them confused in my brain. And so just refreshment in terms of the testing hopefully will pay off for you. All right, so let's get going. So the first question, and I appreciate Whitney's going to drive this for us, and she typed it, and God knows if I don't thank her, I'll hear from her. Am I wrong about that, Whitney? No.
Thank you.
Yeah, sure. And I know you've sent me a big gift. Okay, so look at the first question. So when you're looking at questions like the manifestations of lysosomal storage disease depend on the accumulated material of the following, the disease is most associated with mental retardation. And that really should have said developmental, kind of mental retardation is an older term, and I apologize for that. But when you look at those diseases, the answer here is going to be Hurler syndrome. Cystinosis is an amino aciduria, you know, and an amino acid problem, not an, and so it doesn't have anything to do with the brain. Fabry's, once again, is kind of a fat buildup, but it's not in the brain. Morquiosis is one of the mucopolysaccharides, but it doesn't have to do with the brain. Hurler syndrome is the classic one with brain. Gaucher's, once again, spleen, bone, but not a brain problem. So you need to kind of get in your mind the lipidoses, the fat ones, which is Gaucher's and Fabry's, et cetera. And then you got your mucopolysaccharidoses and the ones that involve the brain. Now, Hunter's, if that had been there, that would have been an answer. You know, Hunter's and Hurler's, those are all, and there are many of them, but Morquiosis is one of the ones, and that's kind of, you've probably seen those people, and I can't remember the guy on Fantasy Island. Do you remember the guy, oh, what was it, Tutu or TT, what was his name? Oh, y'all don't know Fantasy Island, it was before your time, I'm sure. I'm so sorry. But that used to be a TV show. And here's this little guy on Fantasy Island. Maybe in the James Bonds, you know, the little, that's more of the Morquioi person. You know, mentally they're fine. This is all physical disability, et cetera, et cetera. So the answer here is going to be Hurler syndrome. Okay, next is a breastfed infant who comes in. A lot of people miss this one. So we'll go over it a little bit more. And this is a hard question. This is almost a question that points at a database. And what I mean by that is calcified adrenals, boom, boom, boom. It's a database answer. You either have a database of differential of calcified adrenals or you don't. Now, in this particular case, Wolman's disease is the right answer, and that's a fat storage disease to a cholesterol problem. But the key here is just, you've got to get in your mind, what is the differential of calcified adrenals? Waterhouse-Friderichsen, that's one you should know, right? That's the meningococcemia, right? And of course, you could play the game of maybe a tumor but here it's bilateral, so you got to play that game. But it's just kind of a differential. Anything that bleeds into the adrenal could give you some calcifications eventually. But this is relative to a patient with diarrhea, failure to thrive, hepatomegaly. This didn't just happen. This wasn't an acute process. This is a chronic process. So you either know this or you don't. And so it's just an example of a question where you would see that and you'd say, I need to know the differential diagnosis of calcified adrenals, and then put it to the patient, and then the answer falls out. I mean, it's the only thing it could be based on the stem of the question. But if you don't have that differential, then it doesn't help you at all, okay? Now, when you go the other way, glycogen storage disease, that's liver, glucose and galactose malabsorption, that I just made that up. Cystic fibrosis would be, because everybody absorbs glucose, but for some, unfortunately. But in other words, cystic fibrosis would be a disease that now, okay, diarrhea, failure to thrive, whatever, but what is the calcification of the adrenals? So again, not the right answer. So this is a type of question that teases out that one thing in the stem. So you probably should have gotten it down based on what's there, down to one of those two. And CF is the more common disease. I understand that. So this is, like I say, a little bit of a tough question, but it's just trying to expand your ability to say, okay, there are certain things that when I see, I have a differential, and calcified adrenals is one of them, and the answer is Walden's disease. The next one, y'all did well on. This is a newborn that's delivered from a genetics. This is just putting together the charge syndrome, and then knowing the charge syndrome, what does the CHARGE stand for? And then if you know that, here comes the answer. And of course, the A is going to be the heart, so the answer is going to be echocardiography. And the rest of the stuff is, choanal stuff and growth retardation and genital abnormalities, etc. And so this is just classic of I've got to know what the name, what the letters stand for in the name. And you either know those things or you don't. But the charge is a big one. And of course, coloboma is your C, as you well know, that picks that up. And most of you did well with this one. The next one is a diagnosis of an X-linked recessive. And of course, this is just making sure you understand the genetics behind X-linked recessive. And that's a maternal uncle who has the same disorder, right? Now, if you miss this question, this is one you've got to get down. Okay, you're confusing more than likely X-linked dominant versus X-linked recessive. I did. Yeah, okay. And so that is the correct answer here. And again, an X-linked dominant means a girl could have it. An X-linked recessive, classically, a male has it. Now, I say classically because unfortunately in clinical practice, you might see a Wiskott-Aldrich occur in a female. You might see a G6PD deficiency in a female, but that's clinically. On the test, that's an X-linked recessive disorder, those are, and so the answer would fall out accordingly, okay? But again, due to some other sorts of things that can occur, clinical practice might differentiate other words. Okay, let me see, hold on, I just want to be sure people are hearing. Okay, number 5. All right, a 3-month-old comes in. Now, this is a 3-month-old, recurrent episodes of hypoglycemia. She does have hepatomegaly, a 2-hour fast, she gets hypoglycemia. So this question would be most helpful in determining the etiology, okay? So when you think about hypoglycemia, what is your first stratification? Do they form ketones or not, right? Because if they don't form ketones, you go down this pathway, correct? Correct? And if they do form ketones, you go down this pathway. So over here is kind of fatty acid and hyperinsulin, you right? So the way the question reads, because I can understand how you may say, well, I'm going to do an insulin and glucose level in the serum. Not bad, looking for things that may be hyperinsulinemic. And therefore wanting to know what is the insulin level related to the glucose. Not bad. And that might end up being a next test, but that's not the question. The question starts most helpful most helpful. It's the first step of the stratification. So you always want to get in a hypoglycemic state, assuming it's not a diabetic. You know why a diabetic is hypoglycemic, right? too much insulin relative to intake? No. But in this case of a 3-month-old, you have to do it. Now, the other thing is to look at a 3-month-old with just a 2-hour fast. What are the diagnoses? So let's go a step further here. Would this be, if I'd put down galactosemia, would you have bitten on that? Because it has hepatomegaly, they have hypoglycemia. Exactly. So this is an age-related question too. So when you look at a question, take the age into account, because a galactosemic presents at 2 weeks, 3 weeks, right? And vomiting is the big ticket item for a galactosemic. Okay. Now, you might want cataracts there. It could be a problem there because the cataracts don't form at 3 weeks. And the answer is still galactosemia, just because they don't have cataracts, because that takes time. So if you had the older kid with cataracts, so my point is that you can't just say, oh, I know what's associated with everything. Yes, you do need to know that, but you've got to go a step further. You've got to understand, for example, if I'm looking at a neurocutaneous syndrome and I'm looking at the Ashley spots in TS, I have to know they may not be there in a 3-month-old. That takes time to develop. You see what I'm saying? So you need to take that next level and have a clarity of reading more, understanding a little more, and not just stopping at, okay, Ashley spot TS, hypoglycemia, galactosemia. Do you see what I'm saying? That's what they're doing. They're going to a little bit of that next level to be sure you understand the depth, if you will, a little bit more of what the question may be. Okay. Number 5, let's see, I wrote on one, and y'all did pretty good on this one, which is good. Okay, so this is a 3-month-old infant for the evaluation. Oh, wait a minute, that's the one. Oh, no, let me come back to this. What is this diagnosis? I'm sorry, I didn't finish it up. What is the diagnosis here? What would be the diagnosis with if the patient had ketones and reducing substances in the urine? If that were positive, what would this diagnosis be? Jaya says it's not galactosemia because galactosemia would have ketones and would have reducing substances, right? Galactose is a reducing sugar, a reducing substance. Your reducing substances are carbohydrates. There's only one carbohydrate classically that's not a reducing substance. What is that carbohydrate? All together. Sucrose, right? Because if you go back to your 2 monosaccharides, your glucose and your fructose, and remember what makes a reducing substance, that OH that opens and closes at the end of that ring, remember? You know, chemistry 101. And so you take that opening and you take that opening of the other monosaccharide and you turn around and you connect them. You didn't take biochemistry? Oh, I mean, this is biochemistry. Okay, yeah, well, I'm refreshing those who did take biochemistry. Are you following what I'm saying? You take the 2 monosaccharides and you turn the one around and they connect those 2 opening ends that makes it a reducing substance, reduces Benedict solution. You did it in chemistry 101. You put it, it turned from blue clear to blue. Yeah, that's that. Yeah, that's what you did. Okay, oh, please don't patronize me. Okay, so you flip that around, you hook those together. There's no reducing end. It's still a carb, but that's the original. And so sucrose is fructose and glucose that are hooked end to end. Remember that in your oligosaccharides, remember you hook them, hook. The final one is still open, hence it's a reducing substance. So all of your disaccharides or dextrose or anything is a reducing substance because they're hooked such that the last one has that open end to reduce. But if you take that open and turn it around and hook it, there is no open end. It can't reduce. I won't start drawing pictures, but just believe me, sucrose is a non-reducing sugar, okay? Okay, take my word for it. Thank you so much. All right, but the point being that therefore, in this question, what is your answer in this age with hepatomegaly, this hypoglycemia? See, this is fructose, hereditary fructose intolerance. Because the age pushes you outside, as Jay has said, of galactosemia. And so you've got to come, if it were positive, into a reducing substance, which one would present. And that's classic hereditary fructose intolerance, right? 3 to 6 months, depending on when you introduce fructose, which is fruit sugar. Does that ring a bell with anybody? Classic set. Thank you, Jaya. I appreciate it. All right, moving right along. Next. Number 6, okay, so number 6 is a newborn in the nursery. The mother has chronic issue of alcohol abuse. This is just saying, do you know the physical stigmata of fetal alcohol syndrome? And, the long philtrum and the thin upper lip is going to be a classic for fetal alcohol. So either you know that or you don't. I mean, but you need to know your dysmorphisms that match the syndrome. You just got to know those, okay? And that's experiential learning, but you just learn those things. Yes, Jeremiah? Well, the complex is the problem. Yes, it could have gotten you with if it just said congenital heart defect. That's right. And that's why the word complex is in there, because that's not the right answer. Okay. And see, so you have to read the words. You can't just say heart defect and then you say they said complex. Why would they have said that? Well, they've said that because that's not the right answer. Okay, but had they had heart defect, that would have been tough, right? Even though you do know the long field. I mean, don't run away from what you do know to make it fit, but your point well taken. All right, number 7, Prader-Willi, okay? So this is looking at your overgrowth syndromes, of course. You have to know the overgrowth syndromes. If I said giantism and visceromegaly, what syndrome is that? Genetic, what syndrome? Visceromegaly and... Could be, but what syndrome? Beckwith-Wiedemann syndrome, remember? I mean, it just of the two. I mean, we're in genetics, so we're in syndromes here. I'm not saying it couldn't be another disease, but you remember I asked that the other student when the student got a little mad at me, and I said, no, you're answering disease. I'm asking you syndrome, right? Those are 2 different words, correct? So you can have a disease that might present, but if it's a syndrome, that's a constellation of things. And in genetics, they want you to know the constellation of things, not to mention maybe what the etiology of the syndrome may be at a certain biochemical level. All right, what's hyperactivity and ataxic movements? Ataxic movements, hyperactivity, that's your happy puppet, your Angelman syndrome, right? What is hypocalcemia congenital heart defect? DeGeorge's syndrome, catch-22, mental retardation. Again, I apologize for that word. Mental retardation and macroorganism, what is that? Fragile X. And then what is obesity and small hands and feet? Prader-Willi. So what's the right answer? That's how you do it. So you can look at it from, if you don't know that small hands and feet were to be part of Prader-Willi, or that Prader-Willis are floppy at the beginning and they're real thin and failure to thrive. And then their obesity kicks in about 4 to 5 years of age, okay? If you don't know that, then go the other way on a genetics question and say, well, I know that's that, and that's that, and that's that. So just by default, that's what's left. And you maybe can get the answer right. Okay, so again, a good test taker does that. They may not know the answer, but they can go back and say, but I know this should go with that, that should go with that. It's not there. I'm just by default, I'm going to answer that. I, of course, would prefer floppy baby, small hands and feet, that's Prader-Willi. Okay, all right. Next. Whitney, yeah. A male infant develops profound hypotonia 24 hours at first. All right, what's the giveaway here? Hyperamminemia alkalosis, right? Done. What is the answer? Perfect. It's a urea cycle defect. That ammonia, galactosemia is a sugar problem. Aminoaciduria is an amino acid problem, and could be part and parcel to a problem with ammonia. I will get, but not 1500. You get a 1500, that's a urea cycle defect. Okay, there's some fatty acid problems that could get you with the hyperammonemia. Don't misunderstand me. But again, this is where, all right, I have a differential of hyperammonemia, but I have a differential of hyperammonemia relative to 500 versus 1500. See how you have to go to that next level? You can't just stop with, I know hyperammonemia and what can cause it. You've got to know it the next level. Yeah, but what gives you a 1500 versus a 300, okay? And a 1500 is a urea cycle defect, okay? Just that's going to be what it is. So, we'll move along. Okay. Now, what can you give me a peroxisomal Give me the classic. What's our peroxisomal classic hypotonic 24-hour baby? Now, not the labs, not the hyperammonemia, not the hypoglycemia, okay? And again, the hypoglycemia would be great for galactosemia, but not the hyperammonemia. You have to put everything together, agreed? So what is, just so you tell me, what's the classic peroxisomal defect that I talk about all the time? The hypotonic, remember Zellweger's, hepatocerebrorenal, remember that's your peroxisomal disease. Now there's some other peroxisomal diseases, don't misunderstand me, but that's one of the classic ones that you need to know. And what are the peroxisomes? You know, the peroxisomes are part of the cell, okay? I know you're going to say you never were taught what was in a cell, right? Is that what we're getting ready to hear now? Okay, all right, got it, good. All right, let's move on. Number 9, a lot of people miss number 9. Okay, and number 9's tough. All right, so what's in this? Well, number 1, it's a healthy boy. He's healthy at 5 years of age. It can't possibly be Tay-Sachs, would you agree? I mean, they can't possibly be healthy, they'll be dead at 5 years of age. I mean, I'm sorry, but they are, you know, I mean, they can't be healthy. Okay, so that one comes off the page. Polysaccharidosis, you know, they're not healthy, you know, they're just not healthy. Krabbe's, oh my word, no, well, life expectancy is 1 to 2 years, et cetera, et cetera. I know there may be an older one, but again, that's one of the ones that's one of the, what did we talk about on Tuesday last week? Krabbe's disease is a what? What's the magic word? It's in your differential of Chris, what did I ask you and you didn't know and you're going to know today? What's the word? Thank you. Leukodystrophy. Remember, Krabbe's is one of the leukodystrophies, right? It's in that congenital, you know, it's a recessive, it's not good. Canavans, leukodystrophy. No, adrenal, look at it. We went through those, all right? So you're kind of down to Gaucher's and Fabry's disease right off the bat. Now, if you know Fabry's is an X-linked disorder, then you might push because it is a boy. So if it were a girl, Fabry's comes off because it's X-linked, but it's a boy. That doesn't mean it has to be an X-linked disorder. So you're basically down to Fabry's and Gaucher's if you look at this question. The giveaway here is the splenomegaly. You know, in fact, one of the workups for, and who was on rounds with me yesterday? Besides Chris, who was with me? Nobody? Oh, Mason, do you remember me going through this yesterday? Yeah. Thank you, dear. Remember, I went through splenomegaly. Remember, and one of the things we talked about, hereditary spherocytosis with splenomegaly that you just found. Talk about SC disease, if you just found a random splenomegaly. But Gaucher's disease is your big, just random splenomegaly. Now, they can have bony problems as they get older and they're different, but that's always in your differential of random splenomegaly would be Gaucher's disease. And they can do pretty well depending on which type they have. So this particular patient, again, with, you know, it's a little bit problematic here, because the angiofibromas that can exist with Fabry's is a little bit tricky here, but the answer here is going to be Gaucher's disease, okay? And it's the splenomegaly that makes it be that answer. Number 10, multiple colonitis. Again, you see this randomness. Well, randomness doesn't fit a nice syndrome. So randomness is going to be something else, and that's going to be the amniotic bands. You know, your fetal hydantoin, which is your Dilantin syndrome. They're, you know, they have intrauterine growth retarded, and they have nail problems, all this other stuff. Varicella, they can have scarring. There's some scarring with it. And just think logically, they have varicella, they've got skin problems, they're going to have scarring. I'm not sure about the maternal hyperthermia, what that gives you, but it doesn't give you this kind of randomness of external visualizations. And then the trisomy 13 doesn't fit this at all. So the answer here is going to be amniotic bands, but the giveaway here is this randomness. Now, please know, it's not on the test, but please know your arthrogryposis. Remember that, no arthrogryposis, they love arthrogryposis. So please look at it before you walk in. Be sure you understand arthrogryposis, because that's a big ticket item for them. And that can be confused sometimes with your amniotic bands, your club feet, etc. So please look at your arthrogryposis and how they may present. All right, number 11, y'all did well with. This is, of course, what? Otter syndrome. Yeah, parental agenesis, all those things are there. What's lissencephaly? Remember, you always have your two brain developmental problems, schizencephaly, lissencephaly. What does that mean? Smooth brain is lissencephaly, schizencephaly is clefting, right? Both are embryonal neuronal developments. Bad news, okay? So I just want you to be sure you know those words because they always occur together and you kind of know what they are. Well, to get the answer, you're gonna have to know the differentiation between the two, right? Okay. Complex congenital heart could be anything, hepatosplenomegaly, we could talk about that from a glycogen storage thing. Diaphragmatic hernia, what is going to be the classic question relative to the diaphragmatic hernia? Pulmonary hypertension. Pulmonary hypertension is the big boy with the diaphragmatic hernia, okay, that you have to deal with, okay? And of course, the physical exam, as you know, scaphoid abdomen, hear bowel sounds, yada, yada. But the question generally is going to be pulmonary hypertension. That's a big deal with the diaphragmatic, okay? Number 12, thrio, vomiting, lethargy, hypertonia, jaundice, hepatomegaly, sure, they can be septic, and they are, because they have meningitis. So what's the gram-negative organism in a 3-day-old? Is it group B strep? I mean, that's not gram-negative, right? So what is it? E. coli. Then you have to put together what disease sets you up for E. coli and galactosemia. And then you have to say, well, what is the defect with galactosemia? And it's the erythrocyte galactose 1-phosphate, right? So the answer here is going to be A. Okay, next two questions. Y'all missed a lot of those, so let's look at those. This is tough. Just look at the stem of that question with the dislocated lens and the thin body habitus and the sclerosis. I mean, two diagnoses ought to pop to brain, right? I mean, just right off the bat. Marfan's and homocystinuria. I mean, those are the classic two that go together. And remember, one whether the lens goes up or the lens goes down. Well, in clinical practice, it can actually go both ways. But the point is, that's one of the discriminators. But they're very similar in a lot of different ways. Now, Marfan's, autosomal dominant, homocystinuria is an enzyme defect. Hence, how do you think that's inherited? Enzyme recessive, right? I mean, if I'm going for an enzyme, I'm going recessive, okay? So you got to decide, well, Now, the pulmonary embolus pushes you toward which of the two? Homocystinuria, right? That pushes you there. The Marfan's would be more, what do you think would have been there for Marfan's? Cardiac, right? Aneurysm, something akin to that. A family history, because it's autosomal dominant. Whereas the recessive, as you well know, can go on forever until the two come together. So this is going to be homocystinuria. So that's the first part you got to know. But then what is the treatment? What's the treatment of homocystinuria? Well, homocystinuria is a real funky disease. I mean, it can kind of go, some people, because it's an enzyme and you can have some activity or no activity. So, they can move along okay, or they can have trouble right off the bat. But basically, it's an enzyme defect, and I won't ask you what enzyme, but I'll tell you what it is. Cystathione beta synthetase. I mean, that's what it is. I don't know that they would ever ask that specifically, but that's what it is. But the trick is, it's a problem with methionine, and so what helps that enzyme be as effective as it can is pyridoxine. So pyridoxine is the answer here, okay, for homocystinuria. And there's that block of homocysteine going to methionine, and so it helps facilitate that particular enzyme. So the answer is pyridoxine. Now, I was getting ready to say something. Sorry, I had a senior moment. But anyway, so the basic, when it comes to a lot of neuronal stuff or a lot of funky, coenzyme Q, pyridoxine, those kind of things, that's kind of the answer of what's down there. If you look at the tetrahydro, that's one of the methotrexate kind of rescue kind of things. Arginine, I have no idea what that would necessarily be. Thiamine, well, if you're got a vitamin deficiency, and of course vitamin D is rickets basically. So the answer here is going to be pyridoxine. Okay. Again, number 14. A lot of people miss 6-year-old girl. Health supervision, low hairline. Well, let me go ahead and tell you what it is. Once again, couple file. Okay, you were probably having to try to think, oh, I know this. Well, they tell you because that's not the question. The question is, what is the most likely clinical feature to expect? Now, this is a tough question because it not only tests you in terms of do you know Klippel-Feil, do you know what goes with Klippel-Feil, and then what is the most common thing of those things that go with Klippel-Feil? But it's a good question to show you depth of information, right? Once again, you can't just say, oh, I know, it kind of goes with that. That's not going to be the question. That's how it used to be. Now they're going to that next level. Of those things, what is the most common? Okay? Because when I pulled this question, I went and I said, okay, well, I know they have those bony problems, and I know they have scoliosis, but it doesn't say scoliosis, it says kyphosis. Well, that's not scoliosis, but I could understand how you could bite there. So once again, knowing the difference. The Madeline deformity is a wrist, it's a wrist, ulnar wrist kind of problem that's in there. That has nothing to do with microtia. What's microtia? Microtia's ear. What is the syndrome? If I'm giving you microtia, what are you giving me back? Without question. I've been over this with y'all not too long ago, and I said, this is one you have to know. Treacher-Collins, remember me going through Treacher-Collins? Autosomal dominant, Treacher-Collins, craniofacial, microtia. And then if you have kind of a unilateral, remember? Goldenhar's, hemifacial microsomia. Well, you had to be present at my talk, Mason, to remember this. That's probably why you're not remembering it. So those are big ticket items. They love Treacher-Collins, okay? That's an autosomal, because, those are the kids that classically come out and they're not breathing well because they have coanal problems. And you intubate them and they're fine because remember, babies are obligate nose breathers. So when you put the tube in, they're fine. And you've got a problem here. Now you can get into the charge syndrome, coanal atresia. So now when you ever see a baby that they set you up, that when they intubate, everything's fine, it's not a lung problem. It's an upper airway problem, and it's coanal, and it's either going to be charge or Treacher-Collins. I mean, those are just what they're going to be. That makes sense? And so that's kind of a pattern recognizer, the classic pattern recognizer. And then which answer is, well, I have to have more information in the vignette to tell you what the right answer is. But in your brain, you just know that, right? That's just a fierce intubate, they're fine. Take them out, they can't breathe. It's coanal atresia, but the question is, why do they have it? That kind of thing. Does that make sense? Okay. And but in this question, so you're down to A and E, and they have both. They can have a Springles, and where's that shoulder blade that flips out there? So they can have both. But the most likely is your conductive hearing loss. It's like if I'm on a test and I get it down, you know how big I told you they love hearing because they don't want you to miss hearing in a kid. I'm going to probably answer hearing. I mean, that's just a mainstay of pediatrics. So the answer here is going to be conductive hearing loss. But it would have been tough there. I mean, if you knew a Springles, this is where in some ways I don't like a question like this, because if you were alert enough to say, I know a Springles goes with this, and I know a conductive hearing loss goes with it, you get no credit for now knowing that, because now you get to get the right answer. You have to know which is the most common. And I just think it works against you when you ought to be giving credit to know that the Springles deformity goes there, because you'd be better off to know it didn't go with it to get the answer right. See, that's why some of these questions, it really doesn't test your knowledge. And so you have to understand that. I mean, or I just go, that's what testing's all about. All right, next is, this is one of the classics, right? The Epstein anomaly that goes with lithium. I think y'all got that. And then you have loose neck skin, non-pitting edema, right? Congenital edema, right? Fetal, okay. And this is going to be Turner syndrome. And so what are you going to do with a Turner syndrome? A chromosome analysis. This is your classic Turner syndrome, right? Right, congenital lymphedema, blah, blah, blah. Okay. And now we're moving into the developmental part. So Dr. Cobb, take it away.
All righty. Okay, yeah, sorry, my feed's a little slow. Okay, now I'm seeing it. So this one is this cognitive test given to a 7-year-old indicating functioning in the moderate intellectual disabilities range. And this is actually a chart that is on the handout that we're going to email to you guys, so that will help you. This is something that you just have to look at the last minute. And parents ask what the future holds. They want to know what she'll be able to achieve vocationally. So of the following, the expectation is that so somebody with an IQ between 40 and 50, that's moderate intellectual disability, like it tells you, which is really nice. That's going to put them at about like a 5-6-year-old level. So they're going to need a high level of support, but they can work. So they are the classic sheltered workshop, the 1 in C. So C can work in a sheltered workshop. The key here is that it says provides close supervision. Below moderate intellectual disabilities, those with severe and profound intellectual disability, generally we do not consider them to be part of the workforce. And then with mild intellectual disability, that's when you get your kind of your semi-skilled or unskilled worker, kind of like you see in B. Although as soon as they put that word competitive job, honestly, that threw it out for anybody with intellectual disability. So they made that one be kind of neither here nor there. And each of these other ones is just not appropriate to that level of moderate intellectual disability. And like I said, in the review sheet, it actually has a chart that has all of this information, so you can just look at it quickly. It is something you just kind of have to commit to memory going in.
So Stacy, just so you know, of the questions that most of them missed, 17 was one that you've gone over, 18 is one, and then 28 in your category, just to let you know.
Perfect, thank you. Yeah, 17, that's always one everybody misses. That's why I put the little chart on your paperwork for y'all. Okay, well, the next one. So mother's concerned that the 5.5-year-old has been struggling to learn the alphabet, numbers in kindergarten, good health, vision screen's normal. Preschool teacher commented last year he was shy, but liked being around other children. So that's already right there. You know, they're not asking about autism because they'd never write that if they wanted you to think of autism. So the most appropriate next step is to do what? And so at this age, we definitely are going to do some, here they only give you psychoeducational evaluation. Any developmental testing would have been appropriate, but we want to investigate some of that difficulty with learning. There were no comments about behavior, so that's why we wouldn't bite on ADHD. Also, most of the time on your board exams, they are really rigid with the DSM-5 criteria, and they are probably not going to throw you an under 6-year-old for ADHD. They might with their new guidelines, but it's unlikely. We're definitely not going to reassure and just sit on this. We always want to investigate to see if there's a problem so that we can do early intervention. Again, nothing behavioral. And then vision therapy is made up. So it exists, but it's made up by those who practice it. So we can go on to number 19. So this is the 9-year-old failing grades in reading and math. So specific classes, which you should note that. So we've got some specific ones. And he achieved motor and language milestones at appropriate ages. So developmental delay is ruled out right there. And teacher reports he's compliant and likable. So autism's probably out with likable, just that word alone. So he tries hard, but continually has difficulty on tests. So he tries hard and he's compliant. So they're kind of trying to tell you it's not ADHD either. Although that speaks more to ODD, they're kind of lumping them in this question. And then he brings home the necessary books. Parents have to help him complete his homework assignments. He likes to be outdoors and get, competitive sports, all these other nice things. His health is good, no change in activity level. So there was another kind of clue in that it's not ADHD. And so the most likely diagnosis is going to be a specific learning disability. They kind of walked you straight through that one as you went through that question. Next up. So 6-year-old girls having difficulty at school, unable to keep up with the curriculum, problem sounding out words, doing basic math. Parents seek guidance in helping her. So this one coming right after the last one, they're asking the same exact thing, except on this one, it's the next step, right? So it is the learning disability, just like the last one, or suspected. So what's our next most appropriate step is that we need to evaluate to see if this is a learning disability or not. And so that is what we would do. We would refer for the psychoeducational evaluation to rule out the learning disability. So all the other things are treating something that we have not diagnosed yet. So we got to investigate what's going on with her learning.
So Stacey, when you're in the realm of a learning disability, the answer is psychoeducational evaluation, right? That's the classic connector to a learning disability,
Yes.
right?
Yes.
That's those connectors that I look at right before I go into test. Because I've got a learning disability. No, I mean, I just have to connect those dots right quick.
Mm-hmm. And repeating a grade is probably never the right answer on the test ever. So just to throw that out there, we don't do that anymore. But that also would be assuming that we already know what's going on with her. So next question. So this is just a brutal milestone question. All of these are. So there are a whole bunch of these because this is what they love to ask you. And I always argue that this is not developmental peds, right? Because my patients never have normal milestones. We never have typical milestones on our rotation. So we hate these questions just as much as you guys do. But they're ones that they love to ask you just over and over. One of my tricks is to really pay attention to the language goals, and you'll see that on the cheat sheet that I made for y'all, it has the language goals written out for y'all. Because if you can't do all of the milestones charts, at least do language, because that generally is going to get you to the right answer, probably 75% of the time. So that's what I have on your sheet. It's not that the others aren't important. It's just that they love to hit you up with those language ones. So in this one, this is literally just looking at a language milestone. So to prove the point that this is the first one up. So he can say dada and mama, and he has one additional word that is banana. So nana for banana. And then she even, to really emphasize it, mama says, no, he doesn't say any other words yet. So if you've been in our clinic and seen us do the little cat clams on the little babies, that is just a 12-month check right there. So one word other than mama and dada. And then we can move on to the next one. So when mom and child enter the exam room for health supervision, so there's another milestone one. The kid says, I want book. Mother takes out her picture book. You ask the girl to find the baby. She looks through the book, points to the picture of the baby, blah, blah, blah. She says, mine. Mom proudly states that her daughter has just begun to combine words. So as soon as I read that phrase, just begun to combine words, that is 24 months every time. It doesn't really matter what else was in the stem. I actually think this one's tricky because she actually says this little sentence, right? I want book. And so when they say, though, she just combined words, it's tricky, but they're almost saying that I want book is probably a rehearsed sentence. So it would be a tidier, easier question if it just said want book, right? Because that's your 2-word phrase. But when mom says she just started to combine words, there's no question. It's got to be 24 months. Next one. So another milestone. You guys got them all stacked together. How fun. This one, it gives you a few extra things. So now we're not just language. We're going to have to look at a couple other things. So I'm just going to highlight things rather than read this long question to y'all. So the big ones that clue you in are the fact that he can draw a cross. So a cross is the 3 to 4 year old skill. And then he says, look at me. So we know that he can speak in sentences. And then he balances on his foot for 3 seconds, which is really like a 3 to 4 year old skill again. So the best answer, this one is kind of tricky. It should be somewhere in between 36 and 48 months, to be perfectly honest. This really should be a 42-month-old kid, but they didn't give you that answer. So most typical would be the older child would be the 48 months, because if the range for these skills is between 3 and 4, most of your 36-month-olds will not have them mastered. So most typical for a 3 to 4 year old range skill set would actually be the 4-year-old. It's just sneaky, but that's why everybody hates milestone questions. Next one. So this one is when he throws the ball, right? Excellent. So kind of the same thing with this one, and mine are in different order. So I'm just looking so I can kind of walk you through the important parts rather than reading through the whole thing. The biggest ones, so he throwing the ball back, and first of all, he gives you the ball. And so that's an 11 to 12-month-old skill. So that's real low. We're going to feel like he can do a lot, maybe a lot more than that. Then he throws the ball to you to play back and forth. That's an 18 to 24-month-old skill. The real clutch one here, though, is he stoops to the floor. He can recover to a standing position. That's 15 months. You can see this is all over the place, this question. This is how they usually are, though. And then you offer him a crayon and a piece of paper. He draws a straight line. And then he sees a few blocks on the floor. He picks up 2 of them, stacks them. That's 13 to 15 months. There's no language milestone really to clue you in. So when you get one of these that has a scatter of different milestones, the oldest milestone wins. I know that seems so weird, but the oldest one wins. And our oldest one is drawing that straight line, which is a 24-month skill. I know, they're just so sneaky. So if you have a big scatter, the oldest skill wins, because that's kind of like, oh, they can do all these things are easy for them. They've mastered all these, and they have this additional skill that's 24 months. If they have a range, if the skill that you can kind of hang your hat on is like if everything's in like a range 3 to 4 year old, like we saw, then you go to the oldest age there as well, the age when they would have mastered all of those things. They're awful milestone questions. Sorry.
But with the thought behind that, Stacey, correct me if I'm wrong, is that before you're going to consider something abnormal, you let them get all the way to the highest age.
Yes.
Before then, here comes the workup. So they're trying to get you to think practically rather than saying, well, because this kid isn't precocious, he's abnormal. No, precocious, great, but he doesn't become abnormal till he reaches the high end of that particular descriptor that's in the test question. Okay.
Yes. Yep. Okay. Next one. Okay, so this one, you guys usually all get this right. So this is just what you do. What is your anticipatory guidance about tantrums? And we just move them to a safe place and ignore them, right? All of these others are just pretty wrong. So the first one is that we're going to change what we do based on whether we're at home or outside the house. And so remember, consistency is key. That would be our biggest advice, consistency. So A is wrong for that reason. Giving her a 10-minute timeout for each temper tantrum. We don't usually time out for temper tantrums anyway. We do let them cool themselves down, but not a forced timeout. And 10 minutes is just super duper way too long for a 2-year-old. Usually we're always thinking 1 minute per age in these young kids. And then we talked about moving the girl to the safe place. Offering a treat if she calms down is bribing her to be quiet. And so she'll only be quiet if you bribe her, is what we will see down the road. And then physically restraining the child till the tantrum is over. She has what sounds like very typical 2-year-old tantrums, other than this kind of long periods of time thing, which in clinic, you would have her define what she means by long. Tantrum time is like seizure time. To parents, it feels like it's been an hour and it's been 2 minutes. So you have to really pin them down to it. So we would not recommend physically restraining the child, although you may see us say different advice in developmental peds. For a typical 2-year-old, we would just ignore them, make sure she's safe so she doesn't hurt herself, and move on. Next question. So this little 3-year-old friend, this is another one of these developmental questions, developmental milestones, but this time they're actually trying to ask you, what's the red flag? So on your little handout, not only does it have a chart of the language milestones, but it also has a little list of common red flags, things that they want you to know to respond to. So really, all of this STEM is this really long drawn out thing. If you looked at the question at the very end of the prompt, right? Find the best support, what finding best supports the need for a speech evaluation in this child. And then you can look up at the top and say, he's 3. Okay, so what I really need to evaluate speech for in a 3-year-old? And then they give you a whole bunch, for the most part, of 3-year-old language milestones. So you got to find the one that would be the red flag. And for him, it would be the 3-word phrases, right? Because he should be talking in sentences. 3-step direction. I wrote all these out just so you guys have these milestones. Yeah, 3-step direction is a 4 to 5-year-old. Identifying 5 colors is 4-year-old skill. Unable to use words to talk about time. At 4, you can talk like past versus present, but really to talk about time is a kindergarten skill, so like 5. And then strangers understanding 75% of your words. That is a 3-year-old milestone, but he should just be achieving it. So the big one is the 3 to 4 word phrases, because he should be already in sentences. Does that make sense? This is another one of these, one of these milestone questions, but they flip to the way they're asking it, but they're checking the same information. Next one. So 7-year-old boy with academic difficulty, did well in kindergarten, but slowly falling behind. Behavioral concerns of inattention and hyperactivity are present. So like the ones that we looked at before that were also learning difficulties or school failure, they did not talk about these behavior concerns. And in fact, they told you like, this is a great kid who always does what he's asked to do. So when you see that language flip, then you know, okay, we're going down an ADHD path. And then we even talk about some impairments of the friendships, and the questionnaires say that we have ADHD. So our next most appropriate step is to treat. And that would be whatever one says something about counseling. Now with the newest recommendations, I should have updated this to not say refer for counseling, but refer for behavioral therapy. That is the language that we're shifting to because they want us to be more specific so that the pediatricians know exactly what to refer to. So behavioral therapy and a stimulant is the right answer. Everything else is the A and B are both, A is more if you were thinking learning disability, which we've already talked about why it's not. The 504 plan at school is a great and wonderful thing to do, but it's kind of an add-on thing. So as soon as you saw one that said try a stimulant plus behavioral therapy or counseling, that was the right answer. We certainly don't need psychiatry yet. And the fatty acids are not evidence-based at this point. So let's get to 28, which is the one I think lots of people struggled with. Is that right?
Correct.
Okay. So This is the 15-month-old who bangs his head when he gets upset and doesn't get his way, as well as when he falls asleep in his crib. He currently says about 5 words. He's ambulating independently. So if those 2 statements say his language milestones are where they should be, so too are gross motor. Obviously, we're assuming everything else is right in those domains, but this is a good indicator. Parents are concerned he's going to seriously hurt himself, and they're puzzled about how to decrease the behavior. And then we have the most appropriate next step. Now, I also thought this one was a fun one. I got to think about this one. So the soft helmet doesn't solve the problem, so that's not going to be the next most appropriate step. We don't really want the parents to hold him while he bangs his head, because he is probably going to bang his head into their collarbones. That's what generally happens. Is if you try to grab a kid who's banging his head, he's going to get very upset with you. First, let me back up and just say, banging your head while you fall asleep in your crib, that part I'm not concerned about. That part we don't treat. That part's fine, actually. It's a kind of a stereotype behavior that even some neurotypical kids will do when they fall asleep at night, or like kick the mattress. It's kind of a sensory seeking deep pressure thing. The bigger concern to me is this consistently banging your head when you're upset, as well as doing it when you fall asleep at night. And that's actually kind of an early onset, this 15-month-old. Most of those kinds of head banging behaviors actually come just a touch later, more in kind of the terrible 2 tantrums. So that's why we do need to do something about this. So that's why we're not going to pick C, that we're just going to ignore this. This is a little atypical, so we do need to do something. And then D, monitor for autism. We never monitor for autism ever. We always evaluate for autism. We never monitor for it, particularly once you've hit this 15-month-old window. That's the whole reason why, as soon as you get, right, you screen for it. And then if the screen is high, you immediately refer for evaluation. So that's why this one is wrong. That word monitor, it like glares like a light bulb, like do not pick me, because we don't monitor for autism. We would always treat. We'd always evaluate. So you only have one option for an evaluation here, and that is the early intervention evaluation. So that is why that one is right. Does anybody have any questions about that one? Since I know that was did you guys get tripped up with the autism part?
Did y'all get tricked with the autism? Some did. They got tricked by the soft helmet.
Soft helmet.
Yeah, so they're trying to say they didn't want him to concuss himself with all this. Right, and then he said, sometimes, and it's kind of interesting, she's saying that because it takes such a long time to get in developmental peds, dig, that's why she put the soft helmet in there. I didn't say that, Dr. Cobb.
Right. No, it's a true statement.
The name will be withheld.
It's a true statement, and that's why they didn't put us on there. That's why they put early intervention, because early intervention should see a patient within 30 days.
Correct.
That's why they put that on there instead, because they knew that you would get trapped by it.
We have 2 minutes for the last 2.
Perfect. So 7-year-old with behavioral problems, academic skills are strong but impulsive, difficulty staying on task. So definitely looks like this is perhaps ADHD, but before we can treat it, what do we need to do? We need to evaluate for it in 2 settings. So complete your Vanderbilt questionnaires. So I assume that most of y'all probably didn't struggle with that. And then of the following, children who are in school and retained are, I don't know that I had this one in my list. Oh, this is a fun one. Okay, so failing in school and retained are, let's see, more likely to drop out.
Howarth wrote this question.
Oh, well, perfect. Let's see if I agree with his answer.
You weren't typing in there.
More likely to drop out of school if retained in the early grades than in the late ones. So that's incorrect. So that one is wrong, because we would like, if you have to be retained, we want you to do it in kindergarten. The earliest grades have the least impact. We don't like to repeat late. So then demonstrate lower rates of dropout. So higher rates of dropout is what they're associated with being retained. So we know that B is wrong. Subsequently more likely to engage in risky health practices. I do not know the data on that, but I would assume sure. and usually engage in suicidal ideation. I don't think that we know that. And certainly usually in suicidal ideation would seem to be a very drastic statement. And then we'll catch up later and become successful in college. They actually have a lower rate of going to college. So I would say, Stalworth, that you said C was the answer.
Correct.
There you go.
C is the answer. Okay, Dr. Cobb, thanks so much. We're kind of at the hour. Any quick questions from the group? Again, we don't have one in December, board reviews. Mason, you know, these are being done for you, not against you, okay? So we'll pick it up in January, okay? And then I'll see y'all the first years this afternoon, right? Okay, bye. Thanks, Stacy. Thanks, Whitney. Crazy. Wow.